have been involved in the care of hypertrophic cardiomyopathy for now 25 years, and we are now following many hundreds of patients. I would say we're in the thousands of patients right now. The frustration that we face every day when treating a patient is the fact that we have drugs available. We can do a reasonable job with the drugs that we have, but I mean reasonable. It's not a very good job. It's not perfect. We are using old drugs such as beta blockers, calcium antagonists such as verapamil, diltiazem, and disopyramide. We use amiodarone. We use anticoagulants. So we have a number of drugs, and these are very useful. I'm not saying that what we are doing now is not useful, and we can solve several problems for the patients. But these drugs usually are aimed at very late consequences of the disease, and they're not specific for the core pathophysiologic abnormalities of the disease. There has never been a single drug registered specifically for HCM, and there is no single drug with class 1A evidence for HCM. So I don't think Mavacamten, unfortunately, I don't think it's the ultimate response. I think there will be more and more progress, and there will be other needs and other drugs developed for this condition and for other genetic diseases. However, Mavacamten is really quite an exciting compound because it is the first molecule that has been designed specifically for hypertrophic cardiomyopathy. It is an allosteric small molecule negative inotrope which binds to myosin and reduces actin-myosin interaction, and by doing so reduces hypercontractility, which is at the base of many manifestations of the disease, including obstruction. In the EXPLORER-HCM trial, we have used it successfully to reduce or even abolish obstruction, dynamic obstruction in hypertrophic cardiomyopathy patients, improves as well as to reduce circulating biomarkers such as NT-proBNP and troponin I, which are long-term predictors of outcome in this disease. And importantly, patients' well-being assessed by specifically developed scores improved very significantly. So patients actually felt better.
Okay, so second question. There are different definitions of HCM in European and American guidelines. Which one is your research focus on, and does this choice affect the evaluation of the efficacy of Mavacamten?
Are you referring to sudden death risk or definition of the disease? I'm not sure I understand the question. So is it aimed at the definition of HCM or the definition of high risk for arrhythmias?
Sorry, a little bit lag for the internet. I think my question is about the different definition of the HCM in European and American guidelines.
So the definition is not different, though. In the definition of the disease is similar. So it's a hypertrophy not explained by abnormal loading conditions or overload of pressure or volume, and it is characterized by a minimum hypertrophy of 15 millimeters or 13 millimeters if the patient already has a genotype or a family history of disease. So the definition and the diagnostic criteria for HCM are really the same worldwide. What really is different is the way that sometimes patients are managed, and also the way that arrhythmic risk stratification is performed. The American system is based on an individual evaluation of major risk factors for sudden arrhythmic death, whereas the European system has proposed a score which combines several risk factors into a single scoring system and gives you a percentage of risk over 5 years. Overall, the two systems are not necessarily the opposite or in competition. I think they can be used in conjunction. They are to some extent complementary. The American system is more sensitive and the European system is more specific. but both can be used and should be used maybe in combination.
Okay, thank you. So in your research or your field of the concern, are there any other new directions for HCM treatment?
Yes, first of all, Mavacamten has proven successful in obstructive HCM, and also in a pilot study has shown promise in non-obstructive HCM. So I think that Mavacamten can be used on a wider scale if we can gain enough information in new studies on larger populations, and this will definitely be done. There is another aggressive inotrope drug that is being developed by another company, which is a very similar concept, and this is still being investigated in a phase 2 trial. So there is still a little way to go before we go to a phase 3 and possibly registration. So this is already a second one, and there definitely will be more drugs in the pipeline right now. We have personally worked on late sodium channel inhibitors such as ranolazine and alaclazine. The former showed limited efficacy on exercise performance, but some promising antiarrhythmic properties in HCM. Alaclazine did not achieve success and was and the development of the drug was stopped. I think a very promising area is exactly this. So the development of antiarrhythmics that are specific for individual genetic diseases. So Mavacamten targets the mechanical effects of the disease. I think it would be nice to develop antiarrhythmics targeting specific channel abnormalities developing either as a direct consequence of a genetic mutation or as a downstream effect, for example, in sarcomere disease. Gene therapy has been attempted in animal models, particularly in models of HCM associated with protein C mutations. And there have been successful early experiences in patients with particular kinds of mutations. And as you know, there has been a correction in the embryo of a mutation, leading to a very promising application of this in sort of in vitro fertilization sort of settings. However, this is unlikely to be a technique. Gene therapy is unlikely, at least in this short to midterm, to be of benefit to the majority of HCM patients, because the problem is that the myocytes in the heart are terminally developed cells. They don't duplicate, they don't divide, and so you would have to target every single cell in the heart with gene therapy in order to be successful and achieve a cure for this disease. So I think this is a long time coming.